And I think the most amazing thing we see is the softening of the skin, which can occur during the first 2 weeks of the conditioning regimen. The nurses on the floor see it, and I think it's just a tremendous gratification for them to see the results of something right before your eyes.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Lenise Taylor, Oncology Clinical Specialist at ONS. Today we're talking with Tanya Helms, a PA from the Division of Hematologic Malignancies and Cellular Therapy at Duke University Medical Center in Durham, North Carolina, about what oncology nurses should know about patients without cancer who require transplantation for autoimmune diseases such as scleroderma, which is Tanya's area of expertise, how the transplant process differs for non-oncology indications, and the clinical pearls oncology nurses should consider for patients with autoimmune diseases. As a reminder, you can earn free NCPD contact hours after listening to this podcast and completing the evaluation we've linked in the episode notes. Thanks for joining us today, Tanya.
Thanks for having me, Lenise. I'm really excited to talk about scleroderma and transplant.
Awesome. Let's get started. Tell us how stem cell transplantation is used as a treatment for patients with autoimmune diseases such as scleroderma and your experience with that process.
Well, first, let's talk a little about scleroderma. So this is an autoimmune disease, and it triggers your immune system to cause inflammation and injury to the cells that line the blood vessels. And then this then triggers the connective tissue cells called the fibroblasts to make too much collagen, which is deposited in the skin, the GI tract, the heart, and the lungs. This leads to thickening of the skin, and it becomes woody or hard, which is the meaning of scleroderma. It can lead to fibrosis in the lungs and the heart. It can cause GI conditions like esophageal dysmotility or gastroparesis, which is slowing of the GI tract. So the treatment for scleroderma is based on the results of clinical trials in the US and Europe. Dr. Keith Sullivan at Duke University was one of the principal investigators in the Scott trial, which was instrumental in showing the effectiveness of autologous stem cell transplant. And I have been involved in managing patients as an APP during transplant process for patients with scleroderma during their inpatient and outpatient stays. Now I work coordinating patients who are referred to Duke, and I manage their stem cell journey through referral, stem cell collection, recovery, and follow-up. And I've been involved with scleroderma since 2007. The goal of treatment for patients with scleroderma is to reset the immune system. And there are 3 main components of the regimen, which is used at Duke. It's TBI radiation, cyclophosphamide, and ATG. This targets all the areas where the immune effector cells live. We also use CD34 selection, which is a process that separates CD34 positive cells from the stem cell product that's collected prior to transplant to eliminate the possibility of reinfusing activated immune cells back into the patient.
Can you describe a little bit more about the main types of scleroderma and which of those are generally considered appropriate for transplantation?
Limited scleroderma may only affect the face, hands, feet, or scattered areas on the skin. This type of scleroderma may progress slowly over years and then stabilize. These patients might have calcinosis, which is calcium deposits in the skin, Raynaud's disease, esophageal dysmobility, and sclerodactyly. They have a relatively good prognosis with a 10-year survival rate of greater than 90%. Diffuse scleroderma affects all of the skin of the body. It is progressive. Patients frequently have Raynaud's symptoms years prior to their diagnosis. But let me say, not all Raynaud's is scleroderma. Their fingers turn white due to vasospasm, then blue due to lack of oxygen, then red when blood flow is restored. The skin progression causes the opening of the mouth to narrow, loss of facial wrinkles as the skin tightens, thinning and retraction of the lips. The hands progress to become claw-like or curled. This is called sclerodactyly. Their extremities become tight and woody, and they may have joint contractures. The skin of the trunk and the chest becomes thick and tight and may restrict their breathing. Diffuse scleroderma will progress to the lungs, and the fibrosis scars the lungs and is irreversible. This can be identified early by changes on pulmonary function tests, particularly the FVC and the DLCO. High-resolution chest CT will show interstitial lung disease. The 10-year survival rate with diffuse systemic sclerosis ranges from 65 to 82%, depending on the progression in the heart, lung, and kidneys. There is a cumulative 5-year mortality rate of 25% from diagnosis. It's not surprising that the patients with rapid progression of interstitial lung disease are the folks with the highest mortality. The goal is to save these people from lung progression. So discriminating between limited scleroderma and diffuse scleroderma and offering transplant, you want to offer transplant to patients who will benefit the most. Patients with limited scleroderma will typically plateau and do well. For those patients, we can't offer much benefit with the transplant. And if we took them to transplant, we are still exposing them to the risk of dying from transplant complications, which we quote at 1 to 2% during the conditioning regimen and recovery period. For patients with diffuse scleroderma, you want to offer transplant when they have evidence of significant disease, but they're not so compromised that they can't tolerate or have increased risk of complications from the conditioning regimen. Understanding the patient's rate of disease progression is key when determining to transplant.
Can you provide us an overview of the referral process for patients with scleroderma who might be candidates for transplantation?
Sure. We have about a 50-50 split between patients who self-refer and patients who are referred by the rheumatologist. We're seeing more early referrals from the rheumatologists who recognize the need to connect patients who have diffuse systemic scleroderma with transplant centers early in the course of their disease. This enables the patient to move quickly to transplant when indicated. And I think there are about 10 transplant centers in the U.S. currently for patients with scleroderma. Patients should look for a center which has experience in transplant for scleroderma and centers with integrated care by rheumatologists and transplant specialists. When a patient is referred, we call the patient and we talk about the disease process in scleroderma and how the transplant conditioning regimen works to reset the immune system and stop disease progression. We explain a workup visit and go over an example of the timeline needed to collect the cells, admit to the hospital for conditioning, and the recovery process as an outpatient. We want patients to understand the big picture before they ever come to Duke. Patients come to Duke for 3 to 4 days. They meet with our scleroderma rheumatologist who evaluates the patient with regards to likely benefit of the transplant. The patient meets with the bone marrow transplant physician to discuss the conditioning regimen and for assessment for any potential complications and other comorbidities. The patient meets with a transplant nurse coordinator, review their calendar, sign consents, and receive additional education. The patient meets with the social workers to discuss housing or other psychosocial needs. The patient's caregiver meets with social work as well to discuss their role in the patient's transplant. The financial counselors meet with the patients and again confirm insurance coverage and the patient's financial responsibilities. The patient will spend a day with radiation oncology. They'll have CT scans and ultrasounds, and these are to allow the radiation oncology team to make blocks that shield the lungs and the kidney from the radiation, as well as determine the radiation dosages. The patient also has to fit in pulmonary function tests, chest CTs, echocardiogram, possible right heart cath, and labs. Some patients might need an EGD if they have a history of GAVE or other GI complications.
That is a lot.
It is. I guess I should add that once the workup is complete, we then submit for final insurance authorization. But of course, we've already assessed if there's insurance coverage prior to the patient coming.
Right, but sometimes those insurance companies, there's that pending referral or their pending approval based on what the final workup looks like.
Correct. And that's a good point. We had that experience recently with a young woman, and her insurance company stated she had to have a DLCO of 65 to proceed to transplant, which is a pretty hard number for some normal people to achieve. And we had to get a pulmonologist to clear her before they would approve her transplant. It was additional 2 weeks of stress and concern for her.
Exactly. What are some of the other obstacles that patients need to overcome in order to have a transplant for their scleroderma?
Well, we've just kind of touched on insurance issues. Another factor, at least in North Carolina, is that we do not have Medicare coverage for this process. I know that some other states seem to be able to get their local Medicare to cover, but we do not have that. There are practical things like traveling to the center. Patients may come from all over the United States. There's the financial impact of paying for housing if their insurance company doesn't cover it. The caregiver, patients have to have someone who can come and be with them 24/7 during this entire process. And some people require teams of caregivers if they don't have one individual who can devote that much time to be away. The caregivers themselves may experience loss of income if they can't work remotely, the expense of travel, expensive childcare if they're leaving children behind. And some patients come to us significantly disabled by their scleroderma. They may be in a wheelchair, so they require special vehicles for travel. Patients whose hands are severely involved need assistance with their ADLs.
And it's a little different than the normal patient that you have, that you're having them get up and walk the halls or making sure they're staying active. That level of activity may look different in that patient with scleroderma.
That's true. That's true.
So you talked a little bit about how autologous stem cell transplant addresses scleroderma. What are some of the issues that transplant may not fully resolve?
So the goal is to prevent disease progression in the skin and the lungs. And there have been 3 clinical trials that show autologous transplant improves event-free survival and overall survival and has been shown to decrease all-cause mortality. But it does not repair damaged GI or pulmonary or cardiac tissue. Any fibrosis that has happened is permanent. Some patients who have diffuse scleroderma and overlap with myositis, they may still experience muscle and joint pain, even if their skin softens. And I think the most amazing thing we see is the softening of the skin, which can occur during the first 2 weeks of the conditioning regimen. The nurses on the floor see it, and I think it's just a tremendous gratification for them to see the results of something right before your eyes.
That is truly something to behold. How has the approach to referrals and workup evolved since the standard of care shifted towards autologous stem cell transplant?
Well, the biggest change, I think, is insurance coverage. 6 years ago, we were appealing insurance denials routinely. Now we may only need to appeal 1 or 2 per year, which is wonderful. We still need to work on the Medicare piece in North Carolina. I think social media has been a huge contributor towards patient self-referrals. Patients are telling their stories on Facebook. Patients are asking other questions about how to get referred to a transplant center. And patients whose rheumatologists have not referred them will seek out transplant centers to learn more about transplant for scleroderma, and they will try to connect for evaluation. And I think it's important that patients advocate for themselves and learn about which disease characteristics are appropriate for transplant, as well as the risks involved. I don't think the workup process itself has significantly changed.
Speaking of the workup, what type of key differences are there between a patient undergoing autologous transplant for a malignant disease versus a non-malignant disease like scleroderma?
I think there is similarity and overlap in the actual workups with regards to the labs and the functional studies, such as the pulmonary function test, chest CTs, echocardiograms, possible right heart caths. I think the difference between these patients is that people with hematological malignancies It's all about getting that patient to remission and then transplanting them with their own cells, depending on the disease, of course. And these patients with malignancies, they've experienced chemotherapy and the adverse effects of chemotherapy. They know about low blood counts and fatigue and recovery. They know about central lines and transfusion of blood products. The scleroderma patients may have had some treatment with IVIG or Cellcept or Plaquenil or methotrexate, but they come to transplant with progressive disease. They've typically not had blood transfusions unless they had a GI bleed, but they're now going to receive total body radiation, chemotherapy, a stem cell transplant over the next 6 weeks. And it can be overwhelming.
Definitely. It's overwhelming for someone who's already been undergoing treatment similar to that, but for somebody who's never seen that, it's indescribable.
It's all new. Every day is something new.
Exactly.
For them to process and learn.
So you talked earlier about CD34 selection. How does this influence the context of auto transplants, particularly for those patients with scleroderma?
CD34 selection is a process that uses a device called the Miltenyi column. And by removing just CD34 positive cells, you are getting rid of any activated immune cells, such as T lymphocytes, from the stem cell product. By preventing reinfusion of these activated cells, you're decreasing the risk of relapse.
Got it. That makes sense. So during the conditioning phase of auto transplant, what are some of the potential complications for patients with scleroderma, and how can oncology nurses manage them for patient safety and successful outcomes?
So these patients become pancytopenic and they are heavily immunosuppressed. They are on steroids during the conditioning regimen to prevent scleroderma flares during conditioning. These patients have a central line, so monitoring for infections, such as assessing vital signs for signs and symptoms of infection, and being aware that steroids can mask a fever. EBV and CMV are viruses that may reactivate, so PCR testing looking for reactivation should be performed and monitored, so making sure these tests are drawn. Monitoring fluid balance and weight with regards to kidney and cardiac function is key. These patients can also experience scleroderma renal crisis, which manifests as increases in the blood pressure. It's rare now for that to occur as we have better medications to prophylax for this, but it's still a possibility and could be devastating. The patient should be monitored for signs of interstitial pneumonitis, which is inflammation in the lungs. This would present as shortness of breath, new or worsening cough, or increased oxygen requirements. Interstitial pneumonitis can progress rapidly and require very high doses of steroids to treat. Prompt notification of the transplant team for respiratory changes is key. Monitoring for cardiac toxicity such as edema, shortness of breath, tachycardia, or bradycardia is essential and would prompt further investigation such as an echocardiogram, consideration of diuresis. Once patients are discharged from the inpatient unit and seen in the outpatient setting, evaluation of the patient focuses on recovery from the transplant, controlling nausea if present, working on physical therapy if indicated, walking to gain strength and endurance, supportive care during the recovery period.
You talked a little bit about the recovery journey and some of the specifics, especially monitoring in the outpatient setting. What are some of the key milestones and considerations during this time?
Barring any major complications during hospitalization, most patients are ready to go home by day 35 to 40 post-transplant. They may still have fatigue. Their sense of taste may still be off. They are still experiencing skin softening, but it may have slowed. This can create some anxiety in the patient, and we have to reassure them that this is a long process and that skin softening can still occur up to a year after transplant. Many patients develop a folliculitis after transplant, which is treated with doxycycline. Before the transplant patient leaves our program, we perform PFTs and echocardiograms. The PFTs usually decline slightly post-transplant and then rebound later. We check the echocardiogram to ensure there are no acute cardiac toxicities. These patients will have some anemia and thrombocytopenia, which will resolve over the next several weeks. They should have their blood counts checked weekly until they normalize. We like to have the patients come back to Duke at 100 days, but sometimes that's not possible if the patients live far away or don't have the resources to come back. We recommend the patients have their immune reconstitution panels checked at day 100. And these are blood tests that look at recovery of the immune system, which is the CD4 T cells and the B cells. The ATGAM that these patients receive during their conditioning regimen depletes the T cells, and many patients have low CD4 T cell counts for a year or longer. This can put them at increased risk for infection, so patients will need to take medicines to prevent against PCP pneumonia while they recover. These patients also need to take medication to prevent reactivation of varicella zoster, which is called shingles. There's a 40% incidence of shingles occurring during the first year post-transplant. Shingles can be devastating, but yet so easily prevented with taking a daily medication such as acyclovir, valacyclovir, famciclovir. We give patients the Shingrix vaccine at 1 year post-transplant. This is to provide immunity against reactivation of varicella zoster. We also re-immunize the patients at 1 year post-transplant for tetanus, diphtheria, polio, pertussis, Haemophilus, hepatitis B, and pneumonia. And there are subsequent boosters that need to be given periodically after that 1 year mark. The patients can come back to Duke for the immunizations or arrange to get them at home. It can sometimes be difficult for patients to get these vaccines at home. Either their primary care cannot get them or the health department doesn't recognize the guidelines for immunizing patients after autologous stem cell transplant. We also recommend yearly flu shots and COVID-19 vaccines. And other long-term follow-up, scleroderma patients with lung involvement need PFTs and chest CTs performed every 3 to 6 months, or if they develop new respiratory or worsening respiratory function. Scleroderma patients without pulmonary involvement should still have their PFTs checked at least yearly as monitoring for disease progression. The scleroderma patients obviously should continue close follow-up with their rheumatologist to monitor their skin, GI, or other organ involvement.
It's a lot to monitor. And if you think about it, the positive point of it is that we've hopefully stalled their disease progression. But there's so much that you have to think about in relation to this. And I want to circle back to the immunizations for a second, just because I know that in my previous role as a clinical nurse specialist for transplant patients, that was one of the most challenging things that we had to address, because this patient essentially has a brand new immune system, just like a baby, but we can't get them all of their vaccinations like we would give for a baby.
Correct. It is difficult. I think the best we can do is when we bring the patients back to Duke, we're able to make that happen. But it's highly variable in the community setting what the patients can get. They can often get diphtheria, pertussis, and tetanus. They often cannot get inactivated polio or Haemophilus. They can usually get the pneumococcal and hepatitis vaccines. And of course, it's not difficult to get influenza and COVID-19 vaccines.
Thank you. I just have a few more questions for you. What's something about this topic that's often not discussed, but you wish people knew more about?
With regards to women, scleroderma can affect the genitals, and women may have vaginal atrophy or fusion. Some women will need to follow up with gynecology and pelvic floor therapists to work with dilators and pelvic floor therapy to improve that muscle tone. With women who are in their childbearing years, we put them into early menopause. And so we always refer back to gynecology and recommend that they receive hormone therapy until they're of an age to where they would have naturally gone through menopause. There's also a risk of secondary malignancies after receiving therapy with TBI, cyclophosphamide, and ATG. So that's why the patient's blood counts should be monitored at least yearly, looking for secondary leukemia. These kinds of risks are discussed in the transplant consents and are certainly real.
Can you think of any additional training or education that oncology nurses would need to further understand stem cell transplantation or maybe scleroderma?
I think the National Scleroderma Foundation has a really good website.
I will also add that ONS has their hematopoietic stem cell transplantation course that people can take, and it's a short 4-hour course that goes over stem cell transplantation in general. So it's a good entree into the world of transplant. Then you mentioned the National Scleroderma Foundation and those resources there. I would imagine those are also for patients and other providers.
Yes, they are. They're very good. I'm not sure how updated the Transplant Center portion of the website is, and they offer continuing medical and nurse education as well.
Well, that's a good way to get some contact hours.
They have a yearly conference, which is very helpful and obviously educational. So if you had a passion for learning about this disease and working with these patients, I would definitely recommend going to the yearly conference they hold.
That sounds fascinating. Tanya, this has been great talking with you.
Thank you.
Do you have any final comments for us?
I think this is a wonderful therapy to be able to offer to patients who previously really did not have anything to stop the progression of their disease. And I know that there is a lot of research with regards to new therapies. There are these things called facilitator cells that are in research. CAR-T is going to be in research for this. And then other biological or immunosuppressive agents that are being researched to try and stop the progression of this disease.
Research. That's the best way to go.
Mm-hmm.
Excellent. Thank you so much. It's been a pleasure talking with you and learning more about scleroderma and stem cell transplant. Look forward to talking with you again.
All right. Thank you so much.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.